Right, hello again. This week I want to talk about the skull, just because I've been talking about the skull this week and I like the skull. But before we go into the skull, check this out. It's gone down a bit, but if you follow me on Twitter, I might have mentioned that I had a bit of a prang on my bike, had a bit of a crash, often do. I do a lot of cycling and I do a little bit of falling off every now and then. You can see how my two elbows are a bit different. So this one's fine. I crashed my bike, fell on my right side, fell on me, crushed on me, landed quite hard on my elbow, my hip and my hand. No biggie, picked myself up and carried on. And about a week later, I was in the gym this morning and I had a massive, great big egg on here. And it's still a little bit squidgy. You can kind of see, oh, there you go, now you can see it. Oh, look at that. So here's the other elbow. Doesn't quite look as bad as that, right? And then here's the damaged elbow. Oh, yeah. How cool is that? So what's causing that? There's a bursa that runs over the olecranon. Ooh, it is squidgy. So it doesn't hurt, it's not painful. It hurts when I bang it. It either started to swell up again because I banged it, or because I was in the gym doing something like, I don't know, dips or something like that. But it was a massive, great big egg. It was brilliant. And I couldn't lean on it then, it was quite sensitive. But there's, so if this is the olecranon, right, part of the humerus, the pointy bit of your elbow that you tend to bang, between the olecranon and the skin there's a bursa which allows the skin to move over it and stuff like that, and I've obviously annoyed my bursa and inflamed it, and it started to make too much fluid and I got bursitis. It's gone down a lot, but cool, huh? Anyway, today's topic, or more accurately, these bits and these bits. If you're studying the anatomy of the skull, you want to know about the bones, you want to know about the sutures, and you want to know about the foramina, the holes in the bones. Now I've made an app and I've made a web resource. I'll put some links in the YouTube thingy down below. So you can get a thing for your iPhone, get an app for your iPhone I made, get an app for your Android phone that I made, probably work fine on tablets as well. And they're just pictures of skulls, and as you touch them or hover over them, it'll highlight the bone, tell you the name of the bone, or the foramina, or the suture, what have you, right? Use that alongside a real skull if you can to learn these structures. It's a beautiful, beautiful piece of anatomy. There's a lot going on here, and there's a lot of important clinical anatomy in the head. Damage to the head tends to have rather profound problems. So the more you understand about the anatomy of the head and this vulnerable part of the body, the better. Now, if we talk about the bones, you probably know about the bones, right? We've got the frontal bone, we've got the parietal bone, parietal meaning wall, frontal at the front. We've got the temporal bone down here. If you have a nice colourful skull like this, that's a bit easier to see, isn't it? Someone drop this. These things are almost impossible to put back together. If you want to keep someone quiet, ask them to take these apart and put them back together. Oh my word. So here's the parietal bone here. It's nice and green, so it's easy to see. Here's the frontal bone here. Here's the temporal bone here. Here's the occipital bone. Here's where the spinal cord comes out. There's the mandible, here's the maxilla, and here's the zygoma here. So the arch, the zygomatic arch, you can see is actually made up of multiple bones. This is part of the temporal bone. The red bone here is the sphenoid bone. You can see that at the back of the orbit as well. So why is the temporal bone called the temporal bone? You know that temporal means time. So how does the temporal bone relate to the passing of time? When it was originally named by the Greeks some thousands of years ago, of course, this is an area of the body that shows the passage of time. In men, particularly, we tend to go grey. You got any grey here? Oh, there's some grey. So this is where men tend to start to go grey first. What about that side? Is there any grey there? Right, so the grey hairs show the passage of time. So the grey in the temporal region shows the passage of time. So this is the temporal bone. Of course, then this kind of gets used by laymen to touching your temples, right? It's not your temples, it's the temporal bone. In fact, it's not even the temporal bone up here, but you know what I mean? Or the only other thing to say about the temporal bone is to look inside. Do you see here? This ridge here. So that's the petrous part of the temporal bone. Petrous meaning rocky. So this is the rocky petrous, there's a rocky ridge of the temporal bone. And the reason that rocky ridge is there is because, look where we are. There's the external acoustic meatus. And it goes in there. So this is where the structures of the inner ear are and the middle ear and stuff like that. So that's why there's a rocky lump there, there's the middle ear. That aside, but what about the foramina? Now the foramina, the holes in these bones, are important. So through these foramina pass cranial nerves and blood vessels and whatnot. So if you know where a cranial nerve comes out of the brain, and if you know how a cranial nerve leaves the cranial cavity, which foramen it goes through, and then if you know where a cranial nerve goes to, what its target structures are, then that's it. You've just described the pathway of a cranial nerve. If you have a patient with an injury or an occlusion or something you're worried about, a particular part of their head, then you can think, oh, well, I know that cranial nerve runs there, so I need to look out for that. Likewise, if you turn that around, if you have a patient with a cranial nerve deficit, so you've done the cranial nerve exam and you found that there's a problem with one of their cranial nerves, they've got a sensory deficit or a motor deficit, and you're scratching your head trying to work out, well, what's caused that? You know where that cranial nerve runs. So you can think about where it is and think about what might be pressing on it or damaging it. So if we're going to look at the foramina, let's start at the top and work our way down. So the cranial nerves are sensibly numbered. So the cranial nerves are from superior to inferior. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, right? So let's have a look. If you're studying a skull, use a pipe cleaner. Don't use a pen or a pencil. If everybody goes poking skulls with pens and pencils, then they leave lots of marks all over the skull, which is a pain to clean off. And these things are expensive. A decent skull is a few £100. Use a pipe cleaner. It's easier to use. We leave a bunch in the lab specifically for that purpose. But also, if you push a pipe cleaner through, you can see where it comes out. And if you know where the pipe cleaner comes out, it gives you a much better idea of where your structures are running. So, starting up here, this is the Cribriform Plate. It's in the ethmoid bone. You see where we are? Look, here's the nose. Sorry, here's the nose. So the ethmoid bone is deep in there. Here's the ethmoid bone up here. So the Cribriform Plate has got a load of holes in it. So what you have here is you have the olfactory nerve running anteriorly, and it ends as an olfactory bulb, and from that bulb lots of little nerve endings pass through those holes to get into the nasal cavity. Those detect olfaction, so smell is carried to the olfactory bulbs and then back to the brain. In between we have the Crista Galli. So gallus meaning chicken, Crista, crest. So this is the cockerel's crest, right? Yeah. So that's the Crista Galli separating the two. If we work down, do you see here that foramen there? So if you poke a pipe cleaner through there, where does that come out? Oh, it comes out in the eye, in the orbit. And it comes out in this, do you see how it's coming out of the canal there? If I poke it back a little bit, you see the end of it. So that's the optic canal. Through there passes cranial nerve 2, the optic nerve. So that's how the optic nerve and the ophthalmic artery runs with it, get to the retina and get to the eye. So you see we're going from cranial nerve 1, cranial nerve 1, cranial nerve 2, and then unfortunately, as we move down, we get to this huge, great big thing here. That is more of a fissure than a foramen, and look, it's in the orbit. This is the superior orbital fissure. So the superior orbital fissure connects the orbit to the cranial cavity. The inferior orbital fissure goes down here, and the inferior orbital fissure, look, is linking the orbit with the deep parts of the face. So blood vessels run through there, do you see? Anyway, what we were interested in is the superior orbital fissure, and through the superior orbital fissure pass cranial nerves 3, 4, 5 and 6. Cranial nerve 3 is the oculomotor nerve. This is innervating most of the muscles of the orbit, most of the muscles that move the eye and other bits and bobs. Cranial nerve 4 is the trochlear nerve, which is going to innervate one of the muscles of the orbit to move the eye. Cranial nerve 6 is abducens, is also going to innervate one of the muscles of the eye to move the eye. Cranial nerve 5 in this case, cranial nerve 5 has 3 branches. So cranial nerve 5, the 3 branches are the ophthalmic branch of the trigeminal nerve, the maxillary branch of the trigeminal nerve, and the mandibular branch of the trigeminal nerve. So we've got 3 branches, and those branches divide before they leave the skull, so they go out through the skull through 3 different holes. The first branch, the ophthalmic branch, goes through the superior orbital fissure. The trigeminal nerve is the main sensory nerve of the face, so most of its branches are doing sensory things. So the ophthalmic branch is going to pass through the orbit, do sensory things in the orbit, and it's also going to be sensory to kind of this region of the face here. It does have a motor component, and we'll work our way down to that. If that's the superior orbital fissure, then this hole here, that is foramen rotundum. You see it? So foramen, and on that side, see, on that side it's there. So foramen rotundum takes the second branch of the trigeminal nerve, the maxillary branch, and if we poke a pipe cleaner through there and see where it comes out, can you see where, see deep in the face? So the maxillary branch of the trigeminal nerve comes out deep in the face, and of course at the maxillary level. So the maxillary nerve is going to be sensory to the maxillary region of the face, including the upper jaw and the upper teeth and things like that. Alright, foramen rotundum. Here is foramen ovale. Do you see how this foramen is oval? So this foramen is an oval foramen, so it gets called foramen ovale. And note the constellation, it's next to this little hole here. So we've got an oval hole and a round hole, and up here is rotundum. So this is foramen ovale, and through foramen ovale passes the third branch of the trigeminal nerve, the mandibular branch. So the mandibular branch of the trigeminal nerve is going to be sensory to this region here, to the lower jaw and the lower face and that sort of thing. But the mandibular branch also has a motor job, and its motor job is to supply motor innervation to the muscles of mastication, to the muscles that move your jaw for chewing and biting. So masseter and temporalis and the pterygoids. All right, that stuff. So that nerve passes down through there. And of course, if you see, look, that nerve, if it passes through foramen ovale, look, it pops out perfectly deep to the jaw so that it can run down to the lower jaw, and also it can innervate these muscles of mastication around here. So I was saying that next to foramen ovale lies this foramen. It's a small hole, and this is foramen spinosum. So it's a small hole, but it's surprisingly important, or at least the blood vessel that passes through it is. There's foramen ovale there, and there's spinosum next to it. Alright, so if I pass a pipe cleaner through spinosum, it comes out here, and you can see how this skull is painted red. And if you look inside a real skull or a really good quality plastic skull, you'll see the impressions and the indentations left by the blood vessels. And what we have passing through foramen spinosum is the middle meningeal artery. Now the middle meningeal artery, as the name suggests, supplies the meninges. It's a pretty useful function, but that's not why it's so important. The middle meningeal artery then runs between the bone and the dura mater, supplying blood to the meninges. The problem is where it runs, and it runs up, you can see it runs on the other side of the bone here. Now we have an area here where we have a number of sutures meeting at the pterion, potentially a weakness in the skull there because of those joins, and this is a plastic skull, so it's thickened and bolstered up a little bit. If you look at a real skull, you'll see that this region of the bone is much thinner than other regions of the skull. So the bone is thin here, you have a bunch of joins that meet here, and you have this blood vessel on the other side, these branches of the middle meningeal artery. So if the bone is fractured here, the blood vessel will tear and the blood will collect in the space between the bone and the dura mater. The blood will push on the brain. It won't contact the brain because you've got the dura mater covering the brain, but it will push on the brain, it will compress the brain, and the person who is bleeding in this space will then fall unconscious. They may regain consciousness sometimes later, they might feel a bit better, they might have a splitting headache, but if that bleeding isn't stopped, if that pressure isn't released, then that person will die from that bleed. So this is the punch that kills boxers. This is the Saturday night punch, or the blow to the head that kills people. So if you have a patient, if you know somebody who's been struck on the side of the head here and they lose consciousness, you should be worried because of the middle meningeal artery, because of these weaknesses. And the middle meningeal artery, as I say, passes through foramen spinosum. So then it's coming from the maxillary artery deep within the face. We've got a hole here, but it's not actually a hole in life. This is called foramen lacerum, so it's a lacerated hole, it's an ugly shaped hole. And it'll look different on different skulls that you look at, but it's not actually a hole. In life it's a joint between two bones and it's filled with cartilage, so it's a cartilaginous joint. And we can see that here. So we're looking at, so there's foramen ovale there, look. There's spinosum. And there's this hole here, just posterior to them. So we've got the sphenoid bone here and the temporal bone here. And in life, those bones are connected by cartilage. So in life, there's not really a hole there, so nothing really passes through it. A few emissary veins linking the inside and the outside of the skull, but that's it. But next to it, here, we do have a very cool hole. If I pass, I'm going to pass a red pipe cleaner through there, and it's going to come out there. And this red pipe cleaner is pretending to be the internal carotid artery. So it's passing through the carotid canal. And you can see again, because of the groove in there, that groove is formed by the internal carotid artery. And so the internal carotid artery actually sits in that groove. And the shape of the bone, of course, is formed by the internal carotid artery. So the internal carotid artery sits there, and it ends about here, and then it splits into the anterior. It splits into the anterior and middle cerebral arteries there. So that's the carotid canal, and you can see how then that artery is actually covering foramen lacerum, rendering foramen lacerum even more useless than it was. So that means that the internal carotid arteries are passing through the carotid canal like this and then going up again. So we've kind of got this S shape to the internal carotid arteries. So if you're looking at images of the skull and you're looking at these levels, then you can look for those shapes to orient yourself and see where you are and look for the arteries. If we see the internal carotid artery coming out here, we can see another hole next to it. Now the carotid canal is this lovely round tube, and it's a canal because it's longer. A foramen is just a hole in the bone. But this big ugly hole next to it, on this model is painted blue, that's the jugular foramen. So through the jugular foramen passes the internal jugular vein. So that's how the internal jugular vein leaves the skull. So the dural venous sinuses collect all the blood from the brain, and eventually most of that leaves the skull through the internal jugular vein, through the jugular foramen. But why is the jugular foramen so big and so misshapen? Well, the reason is because also 3 cranial nerves pass through it. Cranial nerves 9, 10 and 11. Of course, if you look in the neck, you'll have seen probably that you have the internal jugular vein, the internal carotid artery, and the vagus nerve running together within the carotid sheath. So those all drop out of the skull at the same point here and then run together down the neck. So the vagus nerve comes out here. So that's cranial nerve 10, and cranial nerves 9 and 11 run with it as well, the accessory nerve and the glossopharyngeal nerve. So cranial nerves 9, 10 and 11 drop out through the jugular foramen. So we've jumped a little bit there, haven't we? We need to think about cranial nerves 7 and 8. We saw 6 going through the superior orbital fissure, We see 9 going out through the jugular foramen. So what about 7 and 8? Right, well, you know I was talking about the petrous part of the temporal bone up here. Well, there's a hole that goes into it here. And that is the internal acoustic meatus. The external acoustic meatus is out here. And of course you know that you can't stick something through the external acoustic meatus and expect it to come out in the internal acoustic meatus. There's stuff in between. You've got all that inner ear stuff for sensing sound and balance and proprioception and all that stuff, right? So if you stick a pipe cleaner in here, okay, this is a plastic skull, but if you did it with a real skull, you'd have the same problem. If you stick a pipe cleaner through there, it doesn't go anywhere. But in through that internal acoustic meatus run cranial nerves 7 and 8, the facial nerve and the vestibulocochlear nerve. So it shouldn't be too surprising that the vestibulocochlear nerve goes in there, because it's going to go to the vestibular apparatus and the cochlear apparatus. It's just going to go in, split into 2 and carry sensory information from those 2 things. But the facial nerve goes in there, and then it splits into a number of branches which find their way around the structures of the inner ear, and then they pop out in a number of places. So they'll find their way through cracks and what have you in the bone here to get to the anterior parts of the face. So the facial nerve is the snotty, weepy, dribbly nerve of the face. It innervates a couple of salivary glands, innervates the lacrimal glands, innervates the nasal mucosa, so you make snot, all that sort of stuff. So it's going to go to a lot of places in the face. It's going to be very motor. It's going to be very busy. It's also going to carry sensory innervation from the anterior 2/3 of the tongue. And it's also going to innervate all of the muscles of facial expression, right? So if we look on the base of the skull, we find that hole there. So this pointy bit is the styloid process. This rounded bit here is the mastoid process. You can feel the mastoid process under there. In between the two, we have the stylomastoid foramen. And the facial nerve comes out through there, or part of the facial nerve appears from there. And it runs around to the parotid gland, passes through the parotid gland, doesn't innervate it, and then gives off 5 branches which innervate all the muscles of facial expression. So that's where the facial nerve goes. And I say it comes out through a few other places as well. So that's the stylomastoid foramen. Oh, it's got a bit of orange fluff in there. What about this big hole here? So this is Foramen Magnum, literally big hole. So through Foramen Magnum passes the spinal cord, or more accurately actually, the medulla oblongata passes through Foramen Magnum, leaves the skull. And we have the vertebral arteries coming in through here and other bits and bobs as well. And we also, if you look in the textbooks, you'll also find the accessory nerve, cranial nerve 11, passing through the Foramen Magnum. And that's a bit confusing. Does it go out through Foramen Magnum, or does it go out through the jugular foramen? Well, there's more to the story. So if you think about it, so the spinal accessory nerve is going to innervate trapezius and sternocleidomastoid. It's going to need a lot of neurons to innervate all the motor units of this great big muscle up here. So it's going to be a fairly big nerve. It's going to be quite busy. It's got a lot to do. So what we see is we see lots of rootlets coming from the medulla oblongata and from the spinal cord, which is why it gets called the spinal accessory nerve. Now those rootlets come together to form the accessory nerve, and then that actually runs up into the cranial cavity again through Foramen Magnum, and then goes out through the jugular foramen, right? So it goes in through Foramen Magnum, out through the jugular foramen as a single nerve. So one nerve, one branch on either side. So it doesn't come out of both, goes in then out. That's why the accessory nerve is often listed twice if you look at these labels and things. So we're all the way down to cranial nerve 11 now, so there's one left, cranial nerve 12. And that's a little bit more inferior. Can you see these things here? So this is the occipital bone. These are the occipital condyles, which the skull is resting on top of, connecting to atlas, the first cervical vertebra. And you see a couple of holes here. Ignore these guys, these are running posteriorly, but you can see there's a hole here and there's a hole here. And remember that all the interesting stuff is anterior. So the cranial nerves are all going to want to run anteriorly into the face to do the things that they've got to do. So if you're looking at the occipital condyles, these holes through the occipital condyles, these are the hypoglossal canals. Again, it's a canal because it's a bit longer and the hypoglossal nerve passes through them. The hypoglossal nerve is going to want to go below the tongue, glossus, tongue, so literally hypoglossal. So it just has to go a little way to get under the tongue. So that's the hypoglossal canal. These other holes here, these are condylar canals. They carry veins posteriorly, or carry veins from the posterior part of the skull and what have you. Less interesting. Okay, so I talked very briefly about the bones of the skull, but those foramina linking the cranial cavity to the face and other structures are the most important ones. So make sure you know what they are, know what they're called, you can identify them, and you can remember what cranial nerves pass through them, because that'll just help you understand where the structures are running in the head. And there's a lot going on here, so anything that helps you is useful, is good. Okay, there are also some foramina in the palate I haven't talked about and other bits and bobs. If we talk about the nose one day, we'll add all those and other bits and bobs. But you know, if we start with a foramina, you can kind of grow from there. So if you can, find a skull, plastic skull preferably, or a skull you're legally allowed to study. Find a skull, use some pipe cleaners, study that skull and expand your knowledge of anatomy. Oh, and if you're looking at the sutures, don't forget to relate the sutures to the fetal skull. That's for another day as well. Okay.